Greetings, I am Tylonsheya Barlow and I'm a third-year professional pharmacy student at FAMU. The title of my journal is Ezetimibe added to a statin therapy after acute coronary syndrome. Citation is provided above. The authors are Christopher P. Cannon, Michael A. Blazing, funded by Merck. The background: statin therapy reduces low-density lipoprotein cholesterol levels at the risk of cardiovascular events, but whether the addition of ezetimibe, a non-statin drug that reduces intestinal cholesterol absorption, can reduce the rate of cardiovascular event further is not known. Methods. Objective: for patients with acute coronary syndrome, the drug ezetimibe is added to a moderate-intensity statin therapy for the reduction in cardiovascular mortality, major cardiovascular event, or non-fatal stroke than statin therapy alone. Trial design: multi-center, double-blinded, randomized controlled trial. Location: 1,147 sites in 39 countries. IRB approval: each patient provided written informed consent. The FDA approved ezetimibe for treatment of hyperlipidemia in 2002 based upon its effect of LDL cholesterol and not on its impact on cardiovascular outcomes. Inclusions: either sex, age greater than or equal to 50 years, hospitalized in prior 10 days for acute coronary syndrome, or high-risk unstable angina. LDL cholesterol greater than or equal to 50 milligrams per deciliters. Maximum LDL cholesterol: patients who were not receiving a long-term lipid-lowering therapy. The maximum LDL cholesterol for enrollment was 125 milligrams per deciliters. Patient on chronic lipid-lowering therapy, the maximum LDL cholesterol was 100 milligrams per deciliters. Fasting triglycerides was less than or equal to 350 milligrams per deciliter. Exclusion: clinically unstable, recurrent ischemia symptoms, stroke or TIAs, arrhythmias, planned CABG for acute coronary syndrome event, creatinine clearance less than 30 milliliters per minute, active liver disease, use of statin therapy that had LDL cholesterol lowering potency greater than 40 milligrams of simvastatins. Needed to continue medication with CYP3A4 activity, alcohol or drug abuse, lactating women or women of childbearing potential without effective contraceptive. Investigators' discretion: investigational drugs in prior 30 days or prior enrollment in the study. Subject: acute coronary syndrome patient whom average an age of 65 received ezetimibe addition to a moderate intensity statin therapy. The primary endpoint was a reduction of cardiovascular death, non-fatal myocardial infarction, unstable angina, requiring rehospitalization, coronary revascularization, or non-fatal stroke. The secondary endpoint was reduction of all-cause mortality, major cardiovascular event, or non-fatal stroke. Follow-up: the acute coronary syndrome patient had follow-up visit of 30 days at 4 months and every 4 months thereafter. The acute coronary syndrome patient who discontinued the study drug during the trial were generally followed by means of telephone calls. The blood sample will obtain a randomization at 1 for 8, 12 months, and yearly thereafter for those attending clinic visit. Duration: the median follow-up was 6 years. Population: a total of 18,144 patients were treated. 9,077 patients were on simvastatin. 9,067 patients were on simvastatin plus ezetimibe. Arms: randomization to simvastatin 40 mg daily plus placebo, or simvastatin 40 mg daily plus ezetimibe 10 mg daily. For patients with LDL cholesterol greater than 79 mg per deciliter on 2 consecutive measurements, the simvastatin dose was increased to 80 mg daily. This was subsequently modified to reflect FDA recommendation against use of simvastatin 80 mg. Both groups received standard medical and interventional treatment for acute coronary syndrome. Statistical analysis: an estimated of 5,250 events required to give the study 90% power to detect a 9.375% lower relative risk for the primary endpoint with simvastatin ezetimibe than with simvastatin therapy alone. The Data and Safety Monitoring Board collected 10 safety reviews. Results. Baseline characteristics. From the simvastatin group, demographics. Age 64 years, male 76%, white race 84%. Vital measurement BMI of 28 milligrams per kilogram square. Past medical history, diabetes 27%, hypertension 61%, heart failure 4%, PAD 6%, smokers 34%, myocardial infarction 21%, PSH, PCI 20%, CABG 9%. Medications: lipid-lowering 35%, statin 34%, aspirins 42%. Laboratory creatinine clears 85 milliliters per minute, LDL cholesterol 94 milligrams per deciliters. Post-acute coronary syndrome medication, aspirin 97%, thienopyridine 86%, beta blockers 87%, ACE inhibitors or ARB 76%. Primary endpoint. Cardiovascular mortality, major cardiovascular events or non-fatal stroke, 34.7% versus 32.7%. Heart rate 0.94, 95%. CL 0.89, 0.99, P 0.0616, NNT 50. Secondary endpoints. All-cause mortality, major cardiovascular events, or non-fatal stroke. 40.3% versus 38.7%. Cardiovascular mortality, non-fatal myocardial infarction, urgent coronary revascularization, greater than or equal to 30 days, 48.3% versus 38.7%. Cardiovascular mortality, non-fatal myocardial infarction, unstable angina, hospitalization, and revascularization, greater than or equal to 30 days, non-fatal stroke, 36.2% versus 34.5%. Adverse events. There was no difference in the pre-specified safety endpoint between the groups. This includes liver and gallbladder abnormalities, rhabdomyolysis, myopathy, cancer, and cancer mortality. Discontinuation of study medication because of an adverse event of 10.1% versus 10.6%. Author's conclusion: the addition to statin therapy, ezetimibe, resulted in incremental lowering of low-density lipoprotein, improved cardiovascular outcomes, as well as lowering low-density lipoprotein cholesterol to levels below previous targets, provided additional benefits. Critiques. Strengths. Multi-research, double-blind, and randomized trial, while geographic region, increased number of patients involved. The combination of ezetimibe and statin reduced myocardial infarction and ischemic stroke. Weakness: 42% of the patients in both groups had discontinued the study medication. No improvement of cardiovascular mortality or in rate of death in the ezetimibe and statin monotherapy. Summary of primary literature. The trial conducted by Cannon resulted in that ezetimibe and statin reduced by 2% in myocardial infarction, ischemic stroke patients than statin monotherapy. The percentage reduced was 32.7% in ezetimibe and statin 34.7% in statin monotherapy. The combination of ezetimibe and statin reduced absorption of cholesterol from the gastrointestinal tract by a 24% lowering of LDL levels. The trial benefits were in patients with diabetes and patients 75 years old. The level of LDLs was 69.9 milligrams per deciliter in monotherapy and 53.2 milligrams in milligrams per deciliters in ezetimibe and statin therapy. The difference of the two were 16.7 milligrams per deciliters of LDL levels. Applications conclusion. Overall, the trial benefited myocardial infarction and ischemic stroke patients. The study did have an increased percentage of discontinuation in both groups. While the trial did not benefit much in cardiovascular mortality and rate of death, contrastingly, any of the dyslipidemia drugs, ezetimibe and statin, shared a benefit in patients with diabetes and 75 years old in age. Thank you.